All right, so, oh, yes, ma'am.
Submit the homework like online, or do we bring it on paper?
No, you want to submit that online. So I like to keep everything as digital as possible. So just do that like in a Word document, or if you convert to PDF or whatever, just upload that, and then I can review that. I usually like to write comments in there, and I understand you guys are not pharmacists, so I grade generously. I understand if you get something, a minor point, a little wrong, I will correct it, but I'm not going to like sit there and slash your grade 50% or something crazy like that, right? So again, you guys are all learning. That's to be expected. Okay. All right. So anyway, so here's section 1. We're going to be talking about a little bit of introduction to the course. We'll also talk about things like receptor theory. We'll talk about routes of administration, kind of the basics here, and then we'll get into more detail on things like pharmacokinetics and dynamics. We'll talk about what all that is. So again, just for the overview, this is the basis for Pharm 1 and Pharm 2. This is a 1 credit hour course. We only have like 7 meetings, so it's a fairly short course here. And then we know the 4 homework assignments we talked about. There's 3 tests, 2 25 question ones, and then the 150. And then you need a 75 or greater to pass. I'm sure it's pretty consistent for most other courses here. Okay, here's kind of an overview of the different topics we'll be hitting on throughout the course here. I put an exam review here. This is going to be contingent on us having time to cover all that. I'm hoping that by modifying the course so that way your tests are going to be done before I come in, or that way we'll have the full 2 hours. We'll have a little bit of extra time that I can cover some exam review stuff. We'll just kind of talk about questions that might be on the test and important concepts and whatnot. So that'll be all contingent on time. Okay, so you can look through some of the objectives that are going to be covered in the different sections here. Again, all of those are posted, so if you want to look at those beforehand, feel free. But today we're going to be talking about basic terminology that's important to understand when discussing drugs, routes of administration. When I say routes of administration, anyone know what that means? Sub-Q, IV, IM, PO. What's PO? Oral, yep, by mouth, so good. So we're going to cover all of those. We'll talk about some of the disadvantages and advantages of each one of those. And then we'll talk a little bit about receptor theories. We'll talk about the different types of receptors and some of the basic actions that drugs can have at those receptors. All right, so a few definitions to begin. First off, everyone's heard of ibuprofen, right? Sort of Motrin. Most people are probably taking it at some point in their life, if I had to guess. So when you're discussing a drug, we'll use ibuprofen as our example here. There's a trade name associated with most drugs, especially new ones that are coming out in the market. When a drug company brings a product to market, they have a patent on that drug for a period of time. We'll talk more about that development a little bit later on. But they have a certain period of time. That's when you have a trade name, essentially, for a drug. And it can be used exclusively by that one company. For instance, Motrin is a brand name for ibuprofen, right? Every drug, though, is going to have a generic name as well. This is basically the public sort of designation for it, the chemical name essentially. And so in this case, the FDA, which stands for, anyone know? Food and Drug Administration, yep, so they regulate all of that. They're going to be the ones that kind of regulate whether drugs come out in the market or not here in the U.S. And so they would say, okay, well, this is ibuprofen, essentially, right? So again, when you go to the store, you might find there's some products called Motrin, you might find some that are called Advil, but everything is going to still be labeled as ibuprofen on there, right? When I put drugs onto a test or any kind of quiz or anything like that, I'll always put the generic first, and then I'll put the brand name in parentheses. I would strongly advise you to learn drugs by their generic name because, one, if you're looking at drugs as far as like classes go, oftentimes they share sort of a naming nomenclature, a common naming nomenclature. So for instance, if I'm looking at ACE inhibitors, which are a drug we use for antihypertensives, there's lisinopril, captopril, enalapril. They all share some names, some similar suffixes there. That can be helpful in helping to memorize your categories of drugs, right? However, I'll put the brand name there because some people just know drugs by their brand name. So for instance, there's a diuretic called Lasix. Everyone knows it as Lasix. No one calls it furosemide unless you're one of the nerdy pharmacy people, right? So I will put that in there just for ease of use. However, I do strongly recommend recognizing things by generic there. Anyway, okay, so going from there, talking about the names, we have a pharmacotherapeutic classification. This is basically how we're going to classify the drug in order to put it into sort of a family with other drugs that have similar actions, as we'll see. So in this case, we call this an NSAID, right, which is short for a non-steroidal anti-inflammatory drug. That's good because it kind of tells you already what the drug's doing, right? So what can you tell from that drug already just by the name? So it's an anti-inflammatory drug, good, so it's going to deal with inflammation, and also it's not a steroid, right? That tells you a ton of information right there. We'll talk about steroids quite a bit when we get into Pharm 1 and Pharm 2, but that is a very important classification of drugs we use. So if you ever hear NSAID, that's basically what we're referring to. And then you get down into the actual mechanism of action. What is that drug doing to the body to actually cause its clinical effect. And so in this case, it happens to be a cyclooxygenase inhibitor. There's an enzyme called cyclooxygenase. It's very important for inflammation. Oftentimes it gets abbreviated as COX, C-O-X. And so by doing that, by inhibiting that enzyme, it will decrease the amount of prostaglandin synthesis that occurs, right? And so by interrupting that cycle there, you inhibit inflammation. And again, I'm not going to ask you specifically what's the mechanism of action of ibuprofen. That'll come later. That's for Pharm 1 and Pharm 2. I'd rather you know that, okay, what do I mean by when I say mechanism? Because for your homework assignment, you're going to figure that out. You look up fentanyl or lisinopril or hydrochlorothiazide. You're going to be able to look up to see, like, what is it actually doing to the body to cause its effect. And then we'll look at indications. So these are going to be disease states or reasons why you might use a drug in a patient. So for instance, we might use this as an anti-inflammatory. Say for instance, you sprain your ankle and you're having some inflammation at the site. This can help to deal with that inflammation. We'll use it as an analgesic. What does that mean? Yeah, use it to treat pain, right? It has nothing to do with rectal administration or anything like that, right? Just to clarify. So it is used to treat pain, right? And it's also an antipyretic. What does that mean? Yep, it's going to be helping to break fevers down. So again, you could use this for someone who maybe is coming down with a cold or something. They're having fever. They're feeling achy. This is going to be good for that because it has several indications that you could use it for potentially, right? All right, so when we're looking at pharmacology itself, this is the study basically of drugs in the body. We can also look at things like interactions between drugs. We're going to find that a lot of drug interactions are very, very clinically important. It's good to make sure that we can try to limit those and try to mitigate the negative effects that has on patients as best we can. And you can break it down, pharmacology, into this umbrella into two distinct categories here of pharmacodynamics and pharmacokinetics. We'll talk about what those are. Pharmacodynamics, essentially, the best way to remember this is what the drug is doing to the body. So again, going back to that mechanism of the drug, we're trying to elicit some sort of response. We can try to figure that out by looking at the drug concentration in the body and what kind of effect we're expecting to see. So for instance, if I were to increase the dose of a drug, what should I expect to see with the effect? Should it go up, right? In most cases, you would expect some sort of linear relationship there. This is basically where we're looking both at therapeutic and toxic effects, right? We're going to find there's different mechanisms for that where that can occur there, but this is all relating back to what the drug specifically is doing to the body, okay? So for instance, and again, I use use ethanol as my example quite frequently, and I'm sure none of you have any experience with ethanol, personal use or otherwise. Really familiar with the substance ethanol, correct? Great. Most people probably think I'm an alcoholic by the end of this class because I usually use it as as an example quite frequently. However, it's a very good example, right? Because again, anything you can really consider to be a drug, any sort of chemical, ethanol is a drug just like anything else in a lot of cases. In fact, we used to use ethanol, we used to use alcohol IV to treat things like methanol poisoning, like windshield washer fluid or radiator fluid. We used to use that as an actual antidote for that. So again, it has been used as a drug specifically. Anywho, so looking at things like the pharmacodynamics of alcohol, you can see that by changing the dose, you can change pretty significantly what sort of effects you're going to have. So imagine you have like 1 or 2 drinks, you have that kind of low dose effect, or you're having a loss of inhibitions, you're getting sort of that social lubrication, maybe you're a little bit more bold than you would be otherwise, you might ask that person out that you were kind of scared of before. However, you start to bump up the dose, maybe you're now at say 3 or 4 drinks, and now you're starting to have the slurring of the speech, you're starting to have that incoordination, maybe you become ataxic and you're stumbling around, making a fool of yourself, not a person you were brave enough to ask out, now thinks you're an idiot. Again, not from personal experience, I'm just saying this is what has been reported. And then high dose, you can see things like syncope. You can have people pass out completely. They have amnesia. They black out. They have respiratory depression has led to people dying before, especially when you're mixing with other meds. So again, looking at how that dose, that concentration goes back to concentrate the effects you're going to see on the body, whether desirable effects or toxic effects as we've seen here. Okay. Kinetics, on the other hand, is going to be basically what the body is doing to the drug, right? Because anytime you're introducing these new foreign chemicals into the body's like, hey, let's get rid of this. Stuff looks like it's a toxin. I don't want it around. And so we're going to be looking at the means of metabolism, the means of excretion, the way that we actually absorb and distribute the drug throughout the body. That's all pharmacokinetics. We're looking at relationships between concentration and time. Because you would expect after I give you a dose of a drug, does that drug stick around the body forever? It should be metabolized, it should be excreted, it should go down over time, and this is what we're looking at when we're examining the pharmacokinetics here. So again, we'll talk about the AD-M&E, or the ADME of pharmacokinetics. That usually refers to absorption, distribution, metabolism, excretion. Those are the 4 big components of pharmacokinetics. And this is huge because if you modify any of those, you can very drastically modify the concentration. You can modify how well or not that drug's going to work in the patient, right? So again, going back to alcohol as our example, looking at the pharmacokinetics, you can actually find that there's differences in how the body can actually process the alcohol. So for instance, if you're dealing with an alcohol naive patient, someone who does not regularly drink, I'll assume all of you, you should metabolize roughly 20 milligrams per deciliter per hour. Does anyone know what the legal limit of alcohol is for considering to be drunk? Yeah, so 0.08 is a different unit, but 80 milligrams per deciliter roughly is equivalent to that. So 80 milligrams per deciliter. So I know that if I have someone who comes in, I measured their blood alcohol level, and it's 80 milligrams per deciliter, I know it's going to take roughly 4 hours for them to metabolize off that alcohol, right? Because again, alcohol has a steady rate with that. However, if I were to deal with someone who's a chronic drinker, say maybe they're drinking, say, a fifth of Jack Daniels every 2 days, that is someone who's going to be upregulating those enzymes. They're going to have a much higher amount of the enzymes available to metabolize that alcohol, and they may be able to do like 60 to 80 milligrams per deciliter per hour, right? So they can metabolize that much faster because of the pharmacokinetic changes that have occurred due to them being a chronic drinker. Right. Same thing can happen with drug interactions. You can find that certain drugs will cause other medications that are totally unrelated to be metabolized more quickly, more slowly, and everything in between. So those are why it's so important to look at these interactions, because they can modify the kinetics very drastically there, right? So again, this is the effect of the body on the drugs, how it's handling and changing the absorption, distribution, metabolism, and excretion. We'll have a whole section on this where we talk about all of this in more detail. Okay. You can kind of look at the breakdown here between these two. Looking at the dose of drug, we administer it, and then looking at the absorption, how that occurs. And again, as we will see, depending on the route of administration, the absorption may be great, it may be terrible. We'll see how that can change. But you should get some sort of concentration in the systemic circulation. When I say systemic circulation, I'm basically just meaning in basically the blood flow, right? It's going to be there between the arteries and the veins, just circulating around. Now, all the drug doesn't stay there because a lot of times drugs don't work right there in the bloodstream. They have to partition out into the tissue, right? And that's usually where they're going to be working at. So this is that distribution of where drugs are going into the body to have their clinical effects. Then some amount of that drug is going to be able to be metabolized and then excreted, and that's all going to be basically the pharmacokinetics here. The pharmacodynamics is when you actually get the drug to the site of action, wherever it happens to be. We were talking about ibuprofen. It's that cyclooxygenase enzyme, maybe in the site of inflammation, that's causing its pharmacologic effect. You should see some sort of clinical response, and then that can be broken down further into either toxicity or efficacy. Have we ever heard of like a side effect from ibuprofen or experience? Yeah, so like stomach bleeding, right? So developing a peptic ulcer and developing a stomach bleed secondary to ibuprofen. That would be a toxic effect, but it's still an extension of the actual clinical effects of what that drug does, right? We'll look at ways we can combat that in Pharm 1 and Pharm 2, but that is exactly what we're talking about here. An extension of the clinical effects turn into toxicity in a lot of cases. Okay, some other definitions. Pharmacogenomics, anyone want to take a guess at what that means?
How medicine works in people with different genetics.
Absolutely, yeah. And you don't have to raise your hand. You can just shout things out at me. That's totally fine. You can throw things at me too. That also works. Yeah, but pharmacogenomics is essentially where people's genes are all different, and so you can find big variations in how well drugs may work in some cases. So, for instance, I'll give you one really good example. And speaking to peds, because you have a heavy amount of faculty here that have like good peds experiences, and so you can actually talk to Dr. Levine about this as well. But we had a drug we used to use. Everyone ever heard of like codeine or Tylenol number 3? It was a drug we used to use as an analgesic. We give it for pain, and so one of the side effects you can see with those drugs, especially if you get really high doses, is going to be respiratory depression. The reason for that is because codeine itself is not a very good analgesic. It's kind of a wimpy drug, but the body can convert it over into morphine. Everyone's heard of morphine, right? Very good sort of analgesic. So we'd find that in certain, especially in certain ethnic backgrounds, you'd have some patients who would be very good at converting that over to morphine, and they would get very good effects out of that. That work great for them. Other ethnicities, you'd find they didn't actually convert very much of it over because their enzymes were at different levels, so they worked at different efficiencies essentially, and they didn't convert very much of it over. So they're taking, and they're like, it didn't really work too well for me. All that goes back to the pharmacogenomics. Where that became important clinically is we deal with these kids who are going into the ROR because they had obstructive sleep apnea, usually due to they had their tonsils were too big and it was they're causing a lot of snoring and they just weren't sleeping well, and so we go in and we would go ahead and take out their tonsils, right? And so afterwards, and if you know anything about surgery and tissues that you've now like maybe cut something out of, what happens to that tissue? Well, scars, but also in the immediate after effect, it gets very irritated, right? So again, you can see swelling that occurs there. So we'd have these kids that were very good at converting this drug over to morphine, right? And so we would give this drug to them as an outpatient basis. So we're giving a drug to them they were very good at converting. It can cause respiratory depression, and now they have this very inflamed sort of edematous airway that was also causing some obstruction. So guess what? These kids stopped breathing and they died. So because, not at our hospital, fortunately, but at other places, it's been reported nationwide. Because of that, we said, well, we're just not going to use this drug anymore. So an entire formulary shift. So in pediatrics, you almost never see codeine being used anymore because of these pharmacogenetic differences, and it's too hard to guess who's going to be a good metabolizer, who's going to be a poor metabolizer. So because of that, we just said, well, we're just not going to use it at all. Right. So again, that's how you can see big practice shifts that can occur based on things like pharmacogenomics. Right. Some of these things you can test for. Other things we don't have good ready access sort of tests that are cheap that we can do on a routine basis. So for this one, we don't have a very good one. So we just go ahead and just not use the drug.
Is there age limit? Like you don't want to give codeine to kids?
Probably not. There's not like a set age limit necessarily, but just in our practice, we just took it off formulary altogether. So we would see kids up to 18, and then we just don't use it, right? So you certainly may still see it. And it was that kind of interesting with that drug. And again, this is kind of a tangent, but what's interesting is usually African American patients tended to be the ones that had a better conversion. They would be better able to convert it over into morphine. And so what's interesting is because you guys ever heard of like sickle cell anemia? Basically, they have a lot of pain crises and have a lot of pain issues that come up because of their disease state. And you know, sickle cell also predominantly occurs in which population? African Americans, right? So it's interesting because a lot of those patients actually were managed very well on Tylenol number 3, which had codeine in it, because again, they were also more likely to do well with that drug anyway. So a lot of those patients have been on for years, and then our doctor were like, well, we're not going to use this anymore, and so it's kind of a big deal for those patients specifically. So anyway, that's not going to be on the test specifically, but just know that pharmacogenomics is those changes in the genes and how that can modify how well a drug does or does not work potentially. Okay, so let's look at a drug. What is a drug? Kind of anything, right? We consider anything to be a drug potentially, but basically it's a substance that's bringing about some sort of change in biologic function through its action, right? You kind of consider this a key. We're going to talk about the lock and key sort of mechanism here between drugs and the receptors. Your body produces a lot of chemicals that work very similar to how drugs work. And in fact, all of the drugs we have are trying to mimic or maybe trying to inhibit what your body would naturally be doing anyway by working at these receptors. The receptor is that lock sort of component, and again, they tend to have a certain degree of specificity. So only certain things can bind in them to cause some sort of effect, whether it's to increase a certain biologic effect or to decrease it altogether. And so by something like, say, for instance, activating a receptor, you can cause a particular change. By deactivating it, you kind of inhibit that process from occurring in the first place. Now, all these receptors tend to be proteins. These can be things like enzymes. They can be transport proteins located within the actual cell membrane. Sometimes they're DNA targets. So for instance, when you're doing something like cancer, like what is cancer if you had to describe it to somebody? It's unregulated cell growth, right? The cells are just good. They're dividing like crazy. Well, you need DNA for that to occur. So we can do things like target the DNA with chemotherapy and actually target that, destroy that, and then guess what? No more cells being replicated. Antivirals are another one where we actually target the DNA specifically. So really anything can be considered sort of a receptor as long as the drug's interacting with that. And normally they're going to be playing a pretty big regulatory role. We'll talk about homeostasis quite a bit. And what is homeostasis? The body wants to maintain everything at a steady state, right? It wants to maintain everything at a pretty normal level. Anytime you're modifying this, the body doesn't like that, right? So for instance, if I try to lower your blood pressure by giving antihypertensive, the body responds by doing what? Trying to raise the blood pressure back up via several means. We'll look at how complicated that can be a little later on. But the receptors can also modify themselves as well. So you can find that we can have things like upregulation and downregulation to make a drug's effects more prominent or less prominent, as we'll see. So we'll look at some examples of that later on. But just know that they have a very big role as far as regulatory means go, and they can modify things quite greatly just depending on how many receptors you actually have available to interact with drugs. And again, in order for the actual drug to have effect, it has to actually meet up with the receptor. It has to make that complex so they can have whatever downstream effect it is. So, and again, going back to kind of the basic chemistry sort of thing, there's always going to be an equilibrium here between the drug and the receptor. What would happen if I increase the amount of drug here on this side of the equation? Where does it force the equation to? To the right, right? I force it over to the right because now I have more drugs. So again, that goes to the idea that the more drug I have around, the more of it's available to bind with those receptors, the more effect I should expect to see of that. It's that linear relationship that we're going to see. Now again, this is always going to be up to a certain point because again, if I saturate all these receptors, can you get any more effect after that? No, you're not going to find any additional effects. So we'll talk about that a little later on. We're talking about dose response, probably in the next section of the class here. Okay. When we say ligands, this is sort of a generic term. This is going to be anything that, any kind of molecule that binds to a receptor that causes some sort of chemical signaling. Examples, we have lots of endogenous ligands that interact with our receptors. So we have things like neurotransmitters, epinephrine, serotonin, dopamine. Any of these can be considered a ligand for their respective receptors. A lot of hormones, things like insulin, cortisol. Any of those would be considered that. Drugs can also be considered ligands as well. So things like acetaminophen. Anyone know the brand name for that? Yeah, Tylenol, everyone's probably taking that as well, in addition to ibuprofen. And even like messenger molecules. So things like antibodies that are circulating around could be potential ligands for particular receptors. Now, hormone is just going to be a term we're going to use for any kind of natural substance that is produced in the body and can influence how it's going to grow or develop, or basically your body's drugs, right? It's going to be synthesizing. So things like insulin. What does insulin do for us? Lowers blood sugar, right, by driving it into the cells, right? What does cortisol do? Our stress hormones can actually raise up blood sugar because, again, it's our fight or flight sort of response you're going to see with that when patients get stressed out. Testosterone. It's a masculinizing sort of hormone, right? It's the development of male sex organs. You can find muscle growth. Estrogens and progestins would be on this list as well. So anything that's kind of causing a development or growth of the body is going to be considered hormone here. And again, a lot of the drugs we have are either going to be mimicking the effects of these hormones or maybe trying to inhibit the effects of these hormones, right? So for instance, someone who does not want to ovulate and wants to have protection from getting pregnant, they can take estrogen and progestin. That will actually shut that system down. Right? When we talk about that more specifically, we'll talk about how that works. But we can try to mimic these effects or potentially block them, as we'll see. Or in the same vein, if you have someone who has breast cancer that is responsive to estrogen, we can actually block those receptors and prevent that from developing the tumor anymore, right? So again, one way we can actually enhance estrogen effect, and one way we can actually block it potentially by using different drugs. And then when I mentioned xenobiotic, this is basically any chemical compound that's foreign to the living organism. So when you take ibuprofen, you can also consider that to be sort of a xenobiotic. Okay, toxins, I like toxins quite a bit. These typically are going to be considered poisons of a biologic origin. So for instance, snake or spider venom. Who's new to Florida? We got snakes, I hate to tell you. We got some pretty nasty poisonous snakes. But their venom is considered a toxin because it's actually a biologic origin. How about botulinum toxin? Do we ever use that clinically? It's our Botox, right? Yeah. So think about you ever see your patients walking around like this. Probably they have an actual toxin that's been injected into them, and they're looking very young now because of that. We actually use Botox quite a bit over at Nemours for a different purpose. Usually, like kids with like cerebral palsy and things like that have very bad spasticity. We can actually go in and just like we would use it for aesthetic purposes to paralyze those muscles, we can do it for those kids as well to kind of help relax their muscles. So we use that quite a bit. I'll tell you also that we use Viagra for little kids over at Nemours. It sounds odd, but I'll tell you why that is a little bit later on as well. So sometimes you see drugs being used for different purposes depending on the patient here. Toxicant is kind of a little bit of semantics here, but toxicant would be considered anything of a non-biologic origin. So in this case would be like lead or pharmaceuticals. You might hear me use the term sort of interchangeably, but toxicology, those all fall into toxicology, and basically the study of harmful effects of poisonous drugs in the body. And again, what can be a poison? Anything. It all depends on the dose, right? Oxygen can be poisonous to the body in too high amounts. Water can be poisonous to the body in too high amounts. The example I always go back to, anyone remember the Nintendo Wii? Some of you may have been children when you were playing that. I was still working with a NES. I tell that one of my other students the other day, they're like, dude, had the Atari when I was a kid, so like, you're not that old. Anyway, so the Nintendo Wii, there was a period of time where it was very hard to get, and so there's a radio contest. There's a contest called Hold Your Wii for a Wii. And so these people drank a ton of water, and whoever could hold their bladder the longest would get a Nintendo Wii. Not great, because what ended up happening, the lady got severely hyponatremic, which means what? Serum sodium was very, very low. It got to a point where she actually ended up developing seizures, and she actually ended up dying from that. So the radio company got sued quite a bit for that, because again, even water, something you think is being absolutely essential. I don't know if she got a posthumous Wii maybe placed on her gravestone or something. I would hope at the very least she won the award. But regardless, and again, sometimes we're a little cynical or a little dark humor in medicine, but it's only to fight off the sads that come about. Anyway, right. So again, anything can be a poison. It just depends on the dose, right? So again, we're going to talk about things like therapeutic indexes and how we separate out basically the efficacy, the clinical effects we're looking for versus the actual toxic effects we don't want. Okay, so when I talk about an agonist, basically that's going to be anything that's going to be binding to and activating a receptor, right? So it can either directly or indirectly bring about these events, but it will bind to that receptor and cause it to activate essentially, right? So for instance, we have something like a beta-2 agonist. So again, going back to our RT friend here, albuterol. Albuterol is a very common drug you see most asthmatic patients have. They may carry it around with them depending on the situation, but this is an agonist because it actually goes and activates the beta-2 receptor specifically. You guys remember going over like alpha and beta receptors? This is going to be really important. We're talking about things like cardiovascular system, the pulmonary system. So that stuff will come back to bite you in the butt if you don't remember it. But anyway, by activating the beta-2 receptors, you cause smooth muscle relaxation on the airway, and that's going to allow for better oxygenation. Patients will be able to move air much better after receiving that. So that's an agonist, right? Now, certainly you guys ever heard of like a beta blocker? You can actually have the opposite effect occur. If I gave a drug that was a beta blocker, we're going to call that an antagonist, as we'll see here in a second, but you can see the opposite effects occur in those situations. So when you're having a drug binding to the receptor, there's a term we use called affinity, and that's basically for how well or how tightly the drug likes to bind to the receptor. So again, things with very low affinity, they don't like to bind very tightly. Things with very high affinity like to bind very, very tightly, and those tend to have, you may see that it may be very difficult for those actually to dissociate and to limit its effect. Another term we'll talk about is potency. Anyone know what potency means?
How potent the drug is, how effective are you?
Yes, that's kind of the misnomer. So it's not necessarily how effective it's going to be, but it has to go with how much drug do I need to actually cause the effect I'm looking for, right? So for instance, when you see things that are more potent or have a higher potency, they require less drug in order to get the same effect. So a good example of this would be a few opioids we deal with. So morphine being one. Anyone ever heard of fentanyl before? That's a common drug we'll use in the surgery realm. We use it in ER all the time. Basically, morphine gets dosed in milligrams. Fentanyl gets dosed in micrograms. So again, if I were to give, say, a normal dose of morphine for somebody to say like 4 milligrams of IV morphine for a patient, it's going to be pretty good to help deal with their pain. If I gave 4 milligrams of fentanyl to somebody, they're going to be dead, right? So again, it's really, really important to make sure you take that into account. And in this case, we'd say fentanyl is more potent because I've had issues with that where basically, you guys have heard of EMR, electronic medical records. Even though you think they're great and they're foolproof, they're really not. There's room for errors all the time. I remember we had a patient. It was as a post-op patient. They were getting some pain meds from the anesthesiologist of all people, they're the expert in pain meds. And so normally when you're writing for an order of fentanyl, you normally write for so many mics per kilo per dose. Okay. So again, that's taking the patient's weight into account. Normally you do like say 0.5, you do 1 mic per kilo per dose. Well, this doc, all he wanted to give the patient was just 10 micrograms. That was all he wanted to do was a flat dose. What he ended up putting in was 10 micrograms per kilogram per dose because he wasn't looking at the units. And so I get the order and it's like 2 milligrams of fentanyl. I was like, yeah, you sure you want that? He's like, what are you talking about? He looks at it, he's like, oh no, I definitely don't want that. So again, that was something, of course, the nurse probably would have caught that as well if she had to give like a gallon of fentanyl, but to show you, you have to take that into account because again, you need to make sure that 1 milligram of one drug may be equal to a gram of another drug. You have to take these things into account. And we will talk about equal potency, and we'll talk about the ability to look at two different drugs' effects and try to find out where they kind of meet in the middle, essentially. Right? Yes, sir.
I had a patient that was on Loratab all the time, and he wanted to step up his game, and he went to fentanyl. So he was chewing on fentanyl. That didn't end up very well.
Yeah, for the patches he was chewing on. Yeah. Yeah, not great, right? So again, that's one of those things where, and actually we're running into this clinically from the sort of illicit drug use sort of thing. So again, we're in the middle of an opioid epidemic. I'm sure everyone's aware of it. One of the things they found is that as prescription drugs get more expensive, people end up turning to other illicit substances. So again, people think prescription drugs are safer. They're not going to, have anything, kind of weird located in them, but they'll say, okay, well, they're too expensive now. Let me go to heroin. And so they're starting to use more heroin. You're starting to see those deaths go up. One of the things they're finding is the drug dealers, again, they are not the best chemists that are out there. In fact, I probably wouldn't trust most of them to handle my drugs, but they're trying to get more basic product out of what they have, and so they're cutting it with fentanyl. They're putting in fentanyl, and so these people, if they're not very good at if their quality control is not great, right, as you might imagine, they find that one dose is great, one dose is good, and then this dose has way too much fentanyl, and people dying from that pretty quickly. So again, that's one of those things where potency is a very important feature there. Yeah. So. Anyway, clinically, we're going to find that efficacy is going to be much more important than potency, because when you're actually looking at things like drug references, like when you look up your drug this week, you're going to find that they've taken all that into account. Like they've taken to the fact that we know that maybe 50 micrograms of fentanyl is roughly equal to maybe 2 milligrams of morphine. There's calculations and there's conversions that have been done that they take that into account, right? So that way you're not going to accidentally try to kill your patient just by going off like standard dosing there. But we talk about these features here so that way you understand when you're actually looking at the references what all this kind of means essentially. All right, efficacy is just the ability for a drug to cause a desired effect, and that equipotency is just the relative doses of two drugs to get the same effect, essentially, right? So if I have 100 milligrams of drug A, it should be roughly equal to 10 milligrams of drug B. And again, people have done the research; they've figured this out already. Okay, so talking about a full agonist, this is going to be something that actually, when it binds to the receptor, you're going to expect to see 100% of effect out of that receptor, right? So again, if it stands to reason there's a full agonist, what do you think there also is? Yeah, so there's full antagonist, absolutely. What's kind of in the middle then? Maybe like a partial agonist, right? So yeah, so there's also partial agonism that we'll see as well, where you may only be getting, say, 75% effect, or maybe 50% effect, depending on the drug and how it's interacting with that particular receptor. So partial agonists are going to get a lesser response. So even though you still saturate all those receptors, even though you get the dose very high, there is only going to be a partial effect they're going to see out of that versus something like a full agonist. We'll talk more about those a little bit later on and how that becomes important. And again, just kind of a pictorial example here. Imagine you have a full agonist bind to the receptor, should get 100% effect. However, the partial agonist may be only 50 or 70 or whatever it happens to be, only maybe getting, say, a 5 millimeter mercury reduction in systolic blood pressure, maybe versus 10. Okay. If you were to look at, say, the response versus the concentration of these agonists here, you're going to see that and what do you think is happening at this plateau right here? This saturation, all your enzymes or all your receptors are being bound up essentially. So at this point, you're noticing here that even though I've bound up all these receptors, the full agonist is always going to have more effect than the partial will. Okay. And then there are antagonists, which are basically going to be sitting on the receptor, but they actually don't activate them at all. They're basically going to be sitting on it and preventing any effect from occurring whatsoever. So we mentioned that there's a beta blocker. It will sit on the beta receptors and prevent any sort of epinephrine or anything else from coming on and interacting with it. Usually these are competitive sort of relationships to where they're fighting for the same receptor site. So if I increase the dose of one, I could potentially force it to kick the other drug off and get the effect I'm looking for. So a good example, going back to our opioids, anyone know what the antidote for an opioid overdose is? Narcan, naloxone or Narcan is a drug we'll use to reverse the respiratory depressant effects of opioids. That is an antagonist. Once it binds to the receptors that opioids bind to, it prevents any other further activity, right? So what happens is someone who overdoses on heroin or something, or fentanyl, whatever it happens to be, all that drug is sitting there at the receptor. Well, I want that effect to be reversed. I'm going to give a big dose of Narcan, and that will then kick that drug off the receptor, and then now that is being blocked up, okay? So that would be considered a form of competitive antagonism.
Partial agonist, you double the dose, you'll be able to get the same effect
with the partial? Yeah, that's the thing. Even with the partial agonist, you're only going to get maybe a submaximal amount of effect. So because again, once you hit that plateau, all the receptors are being bound up. It doesn't matter if I add more drug, you're not going to get any additional effect out of that, right? Yeah. Yes, ma'am.
When did you give more versus zero?
It's a very good question. I'll talk about one example here in just a few minutes. Yeah, it's a good segue. Yeah. Yeah, so again, there's different types of antagonism. You're going to find in some cases it could be where the drug will actually bind up the ligand on its own. So for instance, when you get bit by a snake and you have their venom coursing through your veins causing all kinds of coagulopathy and all kinds of issues, I can give an antivenom that is an antibody that will actually bind it up and neutralize it. That's one form of antagonism. More often than not, you're going to run into this sort of competitive antagonism. This is the most common one you're going to run into, whether you're talking about beta blockers or like Narcan as a reversal agent. All these are going to be considered to be sort of a competitive antagonism. Yeah. In some cases, you'll have this functional antagonism. This is more likely to be something like a drug interaction more than anything, where you may actually have, due to the physiologic effects, you would find an inhibition of the drug's action. So as an example, say for instance, I were to give someone an antihypertensive because they're hypertensive, want to lower their blood pressure. However, I give them another medication, something like a steroid, that actually would fight that by causing an increase in blood pressure. So now the drugs, even though they don't share similar actions, are fighting one another physiologically speaking, and there's an antagonism there, right? So we'll talk about some examples, and I can't tell you how many times like I've been walking through the ICU when I was on rotations or something, and you had a patient who has a very low blood pressure. They have sepsis, they have very, body-wide inflammation causing them to be very hypotensive. And so to combat that, they give them what they call vasopressors. Drugs are going to cause vasoconstriction to try to raise the blood pressure up. And so they're on, norepinephrine, they're on epinephrine, they're on phenylephrine, they're on vasopressin, all these drugs, 4 drugs, just maintain the blood pressure. And then I go to look to see what they're on for sedation, because normally these patients are intubated or breathing for them, and you want to keep them sedate so that way they're not conscious of what's going on. And so they're on a drug that actually drops blood pressure. So it's like, well, that doesn't make sense. We're giving one drug that drops blood pressure, and we have 4 other meds that are trying to increase blood pressure. What if we switch them off of this and to something else that's going to be blood pressure neutral? Like, oh, that's a good idea. So they switched them over to something else, and all of a sudden they took 3 depressors off, right? They only need 1 drug instead of 4 at this point, right? So those are the things that, by being, cognizant of these physiologic actions, by looking at the drug interactions here, you can try to hopefully reduce the number of meds a patient has to take, or try to make your drugs that you're using more effective in the first place, right? Just one example. All right, just a pictorial example here, normal natural chemical that would come in and bind to a receptor site. Notice how these kind of fit in. If we were to give an agonist drug, it should share a similar shape enough to the receptor side of things that it can still interact with it and still cause whatever physiologic effect. You can think of the antagonist as sort of being like a cork or something. You're trying to block up the receptor to prevent the agonist from coming along and actually binding to it. Okay, so again, 0 effect should be expected to be seen here because, again, there's no actual intrinsic activity of that antagonist. It just sits there and prevents anything else from binding to it, essentially, right? There's a couple of different types of antagonists you can have. There's reversible and irreversible, and so again, you can kind of assume what that means. It's pretty self-evident. But for example, if I'm dealing with something like ibuprofen versus something like aspirin, right? Aspirin is a drug most people probably heard of at least before. When you think of people taking aspirin like every day, usually for the heart, right? They usually take it for the heart, for cardio protection, right? It helps to stave off heart attacks and whatnot. The reason why people will take aspirin every single day like that, and usually how much do people take? They take a baby dose. You're like, well, you're a full-grown adult. Why are you taking a baby dose of aspirin? I'll talk about what that is in a minute here. But basically, if you have something that's a reversible antagonist, that's something that's going to be, as soon as the drug is away, the effects are gone, right? So for instance, if you take ibuprofen, if I'm taking it for a headache, and all of a sudden the drug is out of the system, guess what? The headache may come back, right? Or if I have a sprain my ankle or something, the pain may come back. That's why you take things maybe around the clock. Maybe I'm going to take ibuprofen every 6 hours. In some cases, and this is the more rare instance, you'll have irreversible antagonists to where as soon as they bind to their target, they're done. Like they're basically going to be there for the lifetime of that receptor, essentially. So in this case, when you're looking at aspirin, the reason why we use it is because it actually has the ability to inhibit platelets from aggregating together, right? Because that's basically what happens during an MI. You have a clot that forms in one of these vessels that prevents further blood flow, right? So to prevent that, we try to inhibit the platelets. Aspirin, we can give a very low dose because basically as soon as it binds to that platelet and it binds to that cyclooxygenase, it's inhibited. It can't do anything anymore. And that's for the lifetime of that platelet. So by just taking a single baby dose at only 81 milligrams, which is not a big dose, every single day, as soon as I'm making new platelets, which you're always making new platelets, those get inhibited and then they're done, right? So then you have that cardio protection essentially that prevents potentially a heart attack. That's because it's an irreversible one. If it was ibuprofen, I'd have to take it every 6 hours consistently. Otherwise, as soon as the drug's gone, the effect's gone, okay? Okay, so we can talk about competitive versus non-competitive. Usually the non-competitive antagonist is going to be binding to some other site on the receptor that makes it so that the receptor cannot bind to whatever that natural ligand is, whatever that drug you're looking for is. This is going to be the non-competitive antagonists are much more rare than what you're going to see with drugs. Usually you're going to be looking at competitive antagonists for the most part. But just know that the non-competitive ones are basically changing it and make it more difficult for the drug or whatever happens to be the endogenous ligand to bind to that receptor in the first place, right? If you were to look at, say you were to combine an agonist versus an antagonist, you can kind of see how it's going to change that effect you're going to expect to see or that response, right? So as I increase the dose of the agonist alone, again, remember there's going to be a plateau effect that occurs when the receptors are saturated. However, if I'm combining with a competitive antagonist, you're going to find that as I increase the dose of both of these, you're going to limit how much effect can actually occur in total because some of those receptors are going to be bound up with the antagonist. Now, say for instance I leave the agonist dose alone, but I increase the dose of the antagonist, how would you expect this graph to look? Start to get lower, right? Because again, I have more of those receptors being bound. It's all a numbers game, right? So if I increase the dose of the antagonist, it's going to cause that effect to be lower. If I increase the dose of the agonist, the effect should go back up, probably pretty close to where the actual agonist alone line is. Again, it's all a numbers game when you're dealing with competitive antagonists. Okay, so this is the graph I like to use to kind of illustrate this. People have heard of methadone before? Right, so methadone is a drug that we use more commonly than not, usually to help people who are addicted to opioids to try to help wean them off of it, essentially, right? It's a very long-acting drug, it's very good for that. Has anyone heard of buprenorphine or Suboxone or Subutex? That's another one that is being used more frequently now as an alternative to methadone to help wean people off of their opioid addiction. So I'll talk about why that is. But basically, if you were to overdose on an opioid, what you'd expect to see is analgesia, which that's a clinical effect, but also the euphoria, which a lot of these people abuse it for. The things they don't want to see are going to be things like respiratory depression, CNS depression, depression. That's what's going to kill the patient, right? And then meiosis is another kind of common clinical finding, right? Meiosis is what? Yeah, pinpoint people. You don't always see that, but that's something you might see if someone's abusing opioids. So we have 3 drugs here. So we have methadone, which is a full agonist. We're going to have buprenorphine, which is a partial agonist, and then we have an antagonist called naloxone. So that's Narcan. That's a competitive antagonist. As soon as it binds that receptor, it prevents methadone or anything else, heroin, hydrocodone, anything else from binding to it, essentially, right? Has anyone ever seen a Narcan reversal? How's it look? It's like The Exorcist. I don't have the clip here, but there's a movie called Bringing Out the Dead. It has Nicolas Cage and Ving Rhames, I think. It's from the 90s. But if you look up Bringing Out the Dead Narcan, you will see a very, I think, pretty accurate to life effect of what happens when you give someone naloxone after an opioid overdose. But it's like The Exorcist. They basically wake up. If you give too much, I should say. Wake up, sitting up straight, puking, diarrhea, all kinds of bad stuff. Again, if you give too much, is a problem. But anyway, that's a competitive antagonist. It directly blocks the effects of those drugs from working very quickly. So anyway, so if you were to look at the opioid effect and looking at the dose that we're administering here, you can see that it doesn't matter how much naloxone I give, how much opioid effect do I see? 0, right? Because it's never going to activate that receptor. It's always going to sit there and block it completely. However, if I have something like a full agonist like methadone, you're going to see that you do get pretty good effects out of that, right? So again, that's what I would expect to see. And if I were to completely saturate all those receptors, you'd expect it to plateau out. Patient would probably stop breathing by that point, right? However, if I give a partial agonist, you notice here that you hit the plateau effect a lot earlier, even though maybe getting close to saturating those receptors, because again, it's only partially activating those receptors, or maybe only get 50% compared to something like a methadone, right? And so one of the things that interesting clinical case is we had a call come into the ER, and it said, oh, this lady overdosed on her buprenorphine. So okay, well, based on what I know about these opioid effects, I'm going to expect her to be coming in very CNS depressed, respiratory depressed, maybe meiotic. Those are what I would expect to see. And this lady came in, and she was going buck wild. She was in restraint. She was trying to kick people and bite people and spit at people. And I said, this lady looks like she's on methamphetamine. She does not look like she just overdosed on buprenorphine. So we finally got her calmed down. We were asking her, like, what the heck is going on? And we said, well, what do you normally take? She's like, normally I'm on methadone. Normally I take all my methadone. I was like, okay. What happened today? Well, I ran out of methadone. Like, okay, so what happened? So I took my friend's buprenorphine. I was like, this is what happened. Because basically what happened in this case, and you guys are familiar with withdrawal, that's basically what you're inducing when you give someone Narcan. They cause that withdrawal because all that effects of the drug's gone. So what happened was she's normally on methadone. She's usually used to a very full agonist sort of effect here, but now she gave herself a drug which is going to come in, and this actually has a stronger affinity for those receptors. It kicked all the methadone off of the receptors that were there and only partially agonizes them. So this means that she basically threw herself into withdrawal even though she overdosed on an opioid. So based on it, we can say, okay, this makes much more sense from a pharmacologic standpoint, why she's acting the way she is, essentially, right? So again, using that information, using that knowledge of mechanism of action and affinities and things like that, you can piece together a picture that looks very odd and make sense, essentially, right? Next, when we talk about specificity, you can find that there are certain chemicals that work on all different types of receptors. That is going to be a case of low specificity when you have things that have kind of a shotgun approach and they affect all kinds of different receptors there. Things with high specificity work on one specific target. And which one do you think might be safer from like a patient sort of standpoint? Have a very high specificity where I only have like maybe one receptor, maybe, right? Because again, what's the problem if I'm affecting all kinds of receptors? You may see mixed response. You're maybe more likely to see toxic effects, right? You can see adverse drug reactions because of that. A really good example are going to be something like antibiotics, right? So again, when I give antibiotics to someone with a bacterial infection, I want to kill off the bacterial cells. I probably don't want to kill off the human cells, right? That's usually the goal. You usually don't want to kill off your patient's cells. Some exceptions to that we'll talk about. But basically, because our drugs are very specific for bacterial targets, you're going to find that they kill off the bacterial cells and have relatively limited side effects for us, right? Still there's some side effects, but it's much more specific for the bacteria. On the other hand, though, if I were to have something that, say, is going to be affecting, say, cancerous cells, right? Those drugs have a very hard time determining whether it's a healthy human cell versus a cancerous cell. That's why whenever you give chemotherapy, what are some of the things you see with those people? Hair loss. They have all kinds of GI issues. Their white cell count goes down dramatically. They can get infections. Yeah, all kinds of bad, because our drugs are not smart enough to tell the difference. Nowadays, we're starting to develop drugs that are a little bit smarter, right? They have very high specificity. But a lot of the old ones we have, they just basically hit everything essentially, all the cells, and we try to help retain the human healthy cells as best we can. But all those cancer cells, you know, they're at the same targets essentially. So again, that's a low specificity. You see a lot more side effects of those sorts of drugs. Another example is like tricyclic antidepressants. I've never heard of like Elavil or amitriptyline. That's kind of an old school sort of drug we used to use for depression. And again, when you think about depression, like what's kind of the worst case scenario that can happen? They try to commit suicide, right? So you give them this drug, and one of the things you'll learn when you talk about psych is that when you have when you first initially start off antidepressants, all of them have a risk of actually increased suicidality. And you're like, well, that doesn't make sense. Why are we giving them a drug that's going to cause them to become suicidal? It's only for a brief period of time, but they were given a drug like Elavil that had a huge amount of side effects with it, and actually was very, very deadly in overdose. So you're giving all these patients who are depressed this Elavil, and all of a sudden they wanted to commit suicide, and they had a very good means to do so. Nowadays, you have much more specific drugs like the SSRIs, like Prozac or Zoloft. You've heard of those. They're much more specific, and they're much safer for the patients, even in overdose. Okay. Yes, ma'am. Sometimes used for migraine prophylaxis, sometimes used for sleep. It can even be used for things like bedwetting in the middle of the night because of the different effects it actually has in the body. So you'll see that one has a pretty wide number of indications you could be potentially using it for. Yeah. Anyway, I did go over on time, so let me go ahead and give you guys a 10-minute break. We'll come back and then we'll continue on. Okay, any questions from the first half that we had there? No one feels... Hopefully no one feels like they're drowning yet, right? It's all concepts. We'll go over some examples. Don't you worry about this. The next concept I want to talk about would be stereochemistry. Anyone know what this means? It's not referring to how chemicals sound or anything like that. You know, the other day I was in a Best Buy and I was kind of getting frustrated because there's all these like record players and DVD players and boom boxes, and I was like, I'm tired of all these stereotypes. All right, that was a bad one. You don't have to laugh at that. It does not improve your grade whatsoever. Maybe professionalism, that's about it. Okay, anyway. Right, so stereochemistry, usually you're going to find that most drugs come as what we call a racemic mixture, right? So again, chemicals have the ability to have sort of a handedness to them, right? So basically there's two versions of it that are not mirror images, or they are mirror images, I should say, kind of like your left hand and your right hand, right? So again, for these chemicals that have this stereochemistry, you typically will find that when they're racemic, 50% is the left-handed version, 50% is the right-handed version, okay? Now, in some cases, you're going to find that the left-handed version may be good for some toxic effects, and the right-handed may be good for the clinical effects, and vice versa, right, depending on the drug. And so in some cases, what drug companies will do is actually separate them out, and when they do that, they actually get a brand new patent off of that. And we'll talk about patents in a few minutes here. So also that could mean they get, new amount of time to actually make some money off of these drugs here, as I'll show you. So whenever you see something like albuterol, if you were to split that out into the left-handed version, you get levalbuterol, a different branding called Zopanex. One of the things to know here, and this is important, is the fact that when I have a racemic mixture, say 50-50, 50% of that is going to be the one version of the drug. So in this case, 5 milligrams of albuterol, if I were to break that out, 2.5 milligrams of that is the Zopanex, right? So because of that, you can get these dose calculations and figure out, okay, what's an equivalent dose of the racemic mixture versus the enantiomer, right? So the enantiomer is what we're talking about, they're left or right-handed. Another example, citalopram or Celexa. Anyone know what that's used for? Depression, yeah, mostly. And then there's escitalopram, which is Lexapro. So again, Yeah, you can use it for anxiety as well. Yep. But citalopram, Celexa, 20 milligrams of that will be equivalent to 10 milligrams of escitalopram. And that's important because when you go to a hospital, like, do you have every single drug known to man on the on their formulary? No, they have to be judicious about what drugs they add there. They can't have to be cost effective. And so, for instance, you have a patient who comes in, they're on Lexapro, 10 milligrams, and we only have Celexa on our formulary. Well, I know that I can convert them from 10 milligrams of escitalopram to 20 of the citalopram. They should get roughly the equivalent therapeutic effects, right? Another one, most people are familiar with cetirizine or Zyrtec, right? That's, been over the counter for a few years now, which is kind of a godsend for a lot of people. They now have levocetirizine or Zizal. So 10 milligrams of cetirizine equals 5 milligrams of the levocetirizine. That makes sense? Right, so again, we do this conversion with some regularity whenever we're having patients who are on certain home meds, and we have to convert them over to our formulary options there. Now, this is interesting that in not all cases is this done for an actually truly therapeutic sort of reason here. Zizal, that levocetirizine, which I thought was very interesting, and they said, hey, wisely designed to be different. This one is so intelligent to be different. It's an active enantiomer of Zyrtec with no dextrocetirizine. We got rid of all that nasty dextrocetirizine, And you look very tiny print down here. The clinical relevance regarding absence of dextrositierazine is unknown. Okay, so you took the one hand, but why? If you don't know if it's clinically important, right? So it's one of those things where, you know, maybe there was some sort of money sort of, you know, monetary sort of influence here. Who's to say? I'm not going to say I'm cynical, but you guys might call me that. We'll see. Anyway. Follow the money is all I'm saying. Now we're going back to talking about receptors. Term downregulation basically means when you have receptors that are normally being, you know, they're normally functioning. You have, say, a set number of receptors at any given time. If I, and again, think back to homeostasis, but if I add an agonist to that, and I'm constantly activating those receptors, causing some sort of effect, what does the body want to do to regulate that? Yeah, it wants to basically decrease, try to get back to what its normal is, so it actually downregulates the number of receptors, or in some cases you desensitize those receptors, so that way the drug is going to be less effective. So that's called downregulation in there. Usually means like fewer number of receptors means diminished drug effect, essentially. Now you'll also see that there's going to be the flip that happens, which is going to be upregulation. That's usually going to be in response to things like antagonists. So if I were, for instance, have a beta blocker that blocks all the beta receptors, the body's going to respond by doing what? Trying to put more beta receptors on the cell surface to interact with things like epinephrine or norepi or whatever it's going to be interacting with. So again, that's an important characteristic here. This is why certain drugs become less effective over time. This is why you may have to adjust the dose up in some cases of these medications to make sure that you retain effectiveness, right? And again, this is all done within some limits, but this is a very common process that occurs here. Yes, ma'am. This could be one of the things you can see with that. So like with caffeine, you know, my body is so saturated with caffeine at this point that I'm just basically drinking coffee just to stay normal at this point, right? I'm not too proud to admit it, but it's one of those things where, yeah, you develop tolerance over time. This is one of the sort of mechanisms that you can develop tolerance. So you have these receptors that respond to caffeine. If I'm constantly agonizing them, the body responds by saying, well, let's just, this is way too much caffeine effect. You know, I can't handle this much. Let's go ahead and drop the number of receptors we have available to make caffeine less effective. That is one way we can see that.
What about the baby aspirin? We are giving that every day. So is that going to increase the production of COX?
What's nice about that is because it's only affecting the circulating platelets. So as you make new platelets, as soon as they're inhibited by the cyclooxygen or by the aspirin, then they're kind of done. So and not in all cases do you see this occur here, but especially in that case, just taking 81 milligrams a day will keep it at a nice steady state level of the drug that it keeps all the platelets inhibited essentially. Yes, sir.
Does the synthesis of receptors also plateau?
Yeah, there would be a limit. You know, you can't just have a cell surface is like just completely littered with them. So again, this is all going to be within reason because again, you know, you can maintain homeostasis for a certain point, but after a certain point, you can only handle so much, right? So yeah, there would be a limit to this essentially. Yep, good question. Okay, some other terms we'll talk about. One's called bioavailability. This is basically going to be the amount or the percentage of drug that gets absorbed through a given route of administration, right? This can vary pretty greatly depending on which route, and we'll talk about routes in a few minutes here. But for instance, intravenous, if I inject a drug directly into your veins, how much of that is in the central circulation, in the bloodstream? 100%, right? So again, that's a very easy way to get 100% drug into the system there. However, if I were to give it orally, and let's say, for instance, we have a drug that gets degraded by the stomach acid, right? pH of the stomach is like 2, very caustic sort of environment. If I give a drug that gets broken down by that, then bioavailability at that point is what? It's going to be 0, right? Because again, think about why we can't give insulin orally. Because it's a protein, right? Proteins get degraded in the stomach. That's the reason why most of our protein-based products have to be injectables, right? Because the stomach acid would just tear them up completely. And so the bioavailability in that case would be 0. And for oral administration, it can vary pretty greatly. For things like rectal administration, inhalational administration, it can vary pretty greatly between 0 to 100 depending on the drug. There's also what we call the first pass effect. Now, when drugs get absorbed from the GI tract, what organ do you think they hit first? Yeah, typically the liver is going to be kind of the first place where a lot of that is going to be going through. And again, we'll find that when you're talking about metabolism of drugs, the liver is the #1 organ where that's going to be occurring, right? It can happen other places, but the liver is kind of the head honcho when it comes to the drug metabolism. So when that drug passes through, kind of have to pay the liver tax, is how I describe it. So a certain amount of the drug, maybe 0, could be 100% potentially, has to go through the liver first, and that's what we call a first pass effect. So then whatever makes it through and gets into the circulation, that's now your bioavailability. So if I lose 50% of the drug by the liver, as a very heavy first pass effect, then that 50% is now my bioavailability essentially, right? That's all that gets through. Well, again, we'll talk about this more when we get to the kinetic section later on. Now, this can be useful. There's things, what we call prodrugs. Anyone know what a prodrug is? It's better than an amateur drug, right? Okay. No, prodrugs are basically going to be drugs that are inactive when given in their natural form. So if I were to take a prodrug and I were to give it, say, via IV, it's not going to be all that effective. It has to go through the liver first to be activated into the actual active form of the drug. So a really good example of this, anyone heard of the drug Vyvanse? It's an amphetamine we use for treating ADHD, right? It's actually a pretty popular one nowadays. Most of our kids over at Nemours tend to be on it. And one of the problems they ran into with a lot of the amphetamines, because again, that's how you treat ADHD essentially, you give them speed basically. Their finding is that people who are trying to abuse it, they would take these like big pills of Adderall or Concerta, and they would just crush them up and they'd snort them. It was basically like doing methamphetamine essentially, right? And so they're like, well, let's limit that. Let's try to prevent that from actually happening. So with this prodrug called lisdexamphetamine, it's Vyvanse, if you were to do that with that drug and tried to snort it, it actually wouldn't be all that effective because it's the prodrug, it's not active. It has to go through the liver first, and then it becomes the active form, and then it can work at that point, right? So that's one way they can actually deter drug abuse by modifying the drug into making it into a prodrug, right? So that's one instance there. And again, it was probably originally made for that purpose, but then it just ended up being very effective, and a lot of people use it anyway. So just because someone's on that drug doesn't mean that they were trying to abuse other stuff. It just means that their doc or the provider probably really liked that drug. Or they got, the drug companies gave them a really, big, nice dinner or something, and they said, oh, let's start using this. All right. There's another term called volume of distribution. This is basically going to be sort of a mathematical sort of concept, but basically kind of trying to describe how far distributed a drug gets into the tissues, right? So you can have drugs that have a very high volume distribution. They're going to be out into all the fat tissues and the muscles and everywhere else. And then you can have things with low volume distribution, like to stay right there within the central circulation, right there in the bloodstream. And we'll cover this much more in detail in the pharmacogenomics section, but just keep that in the back of your mind that there's a difference in how far the drugs can actually go out into the tissues, essentially, based on things like their physiochemical properties, based on how lipophilic or hydrophilic they tend to be, right? Okay, so any questions on any of those definitions we covered so far? We'll talk about all these again, as you'll see. Next up, we have our routes of administration. So what are some different routes we can administer drugs by? IV is a good one. Oral, rectal, inhalation, sub-Q. What's sub-Q stand for? Subcutaneous, good. Intramuscular, topical. Sublingual is a good one. You can have nasal. Any way that you think you can give a drug, chances are someone's probably tried to give a drug that way, right? So again, there's lots of routes of administration. Every one of them is going to have some pros. Everyone's going to have some cons associated with them, right? You can even give drugs via the intrathecal route to give it straight into the CSF, right? Think about women who are going into labor getting an epidural, right? So that's a very important medication. Make sure it's on board, as my wife will tell you. Some funny stories about that. We'll talk about it later, but. Not good to have a couple of pharmacists in the room trying to discuss the merits of the dosing of her epidural and get into arguments. Anyway, so looking at, and this table is not one to memorize these numbers specifically, as you'll see. So what you're going to find, and then looking at the bioavailability, this will make sense based on kind of what we've talked about already. Like IV, it makes sense it's 100% because you're directly putting it to the veins, essentially. Everything else can have some variability. You're going to find the most variability, however, is going to come from oral inhalation, administration, PO, and then with inhalational therapy, you're going to find this can have some variable effects as well. Normally, what you're going to find is when we're giving it via specific routes like the inhalational route, we're trying to keep drugs right there in the lungs, essentially. We don't want a lot of absorption, but you still can get some drugs being very well absorbed from the lungs themselves. Anyone, not that I'm expecting anyone to have any personal experience with this, but anyone familiar with like crack cocaine? You smoke that gets into the system very, very easily. It's very good bioavailability when you smoke crack. Again, crack is whack, don't do it. But you will run into many patients that are going to be recreationally using that product, and that is one way to get it into the system very quickly. But then a lot of other drugs may not be absorbed very well from the lungs. So again, it all depends on the specific substance there, right? But IV is always going to be 100%. Everything else is going to have some variability there, right? And we'll talk about these characteristics in more detail as we go on, but this is a helpful table to kind of go back and kind of reference when you're studying. So IV administration, this is probably the one people are kind of most familiar with as far as like having good bioavailability, good quick onset of action. This one's very, very fast in order to get the drugs into the system as you can, right? Nice thing about this is that because you're directly injecting the veins, it has a good onset, and it's also titratable. When I say titratable, what does that mean? I can change it. I can say how much I'm going to give. So we usually do this via things like continuous infusion of medications. So especially if I was talking about those vasopressors before, things that help to regulate blood pressure. I can give it via continuous infusion, and that way if the blood pressure is too low, bump up the dose. If it's too high, bump down the dose a little bit, right? That's titratable. Now, not every medication is being given via continuous infusion. Oftentimes they're being given via what we call intermittent infusion, where basically I'll give a drug every once in a while as opposed to giving it continuously, right? Because it's not very practical to give drugs continuously like that. It hogs up an IV line for 24 hours. It's no good from that standpoint. Other nice thing, high bioavailability. And I mentioned either you can give intermittent doses known as boluses. You can give a bolus of a drug, or you can give it via that continuous infusion. Now, there's this term we use, central versus peripheral administration. What do you think is the difference there? So yeah, so basically when you're talking about peripheral administration, it's basically going to be out like in the arm, or if you were to say, it's usually the most common place we're going to get it at, but you know, basically you're giving out away from the main central circulation. When you give it via central administration, usually what you're going to find, there's a catheter that's been placed somewhere around the vena cava essentially, right? And so that way the blood volume is much higher, the flow is much higher, and that dilutes out the drug much more quickly. The nice thing about that is because certain drugs are not great, they irritate the veins very much when they're in these like kind of small peripheral veins. Here's an example of a drug called phenytoin, causes what we call purple glove syndrome. And this is a drug that has extravasated, which basically means gone out of the veins essentially, and has caused very severe tissue necrosis, and it will likely require some pretty heavy surgical intervention, probably from plastic surgery, etc. Not great, right? You don't want to do that and get sued by causing that sort of effect. So if I can give it a central administration where it gets diluted very quickly, then you lose a lot of that effect, which is great. So that's one thing we'll look at, you know, so again, certain drugs can only be given via centrally, or we really prefer them to be given centrally. And a lot of this can also be due to concentration as well. So again, things that are less concentrated do better in the peripheral, things that are more concentrated do better when they're kind of centrally administered. But anyway, so those are the two main places you might be giving it. Here is a picture of someone basically they're mixing calcium and phosphate together. And what do you notice about that solution there? It goes from kind of clear to very cloudy, right? That's that drug precipitating out. It's forming calcium phosphate. And so what do you think that does to like an IV line? It's going to block it off, right? What do you think that does to a patient if it gets, you know, and it precipitates out into a small vein or small vessel? It's going to block it up, right? So again, you can cause potential emboli due to this by having drugs that are incompatible with one another. And so there's lots of references we use, but that's one of the things you have to check on, especially nursing, between nursing and pharmacy, to make sure the drugs are compatible together. So when you run them at the same time, you're not going to have something like this happen, right? They could potentially harm your patient. You know, best case scenario, you just have to change the line. Worst case scenario, the patient now has an emboli that you have to deal with, right? So, other things as far as disadvantages, you cannot take what you have already given. You can't take it back, right? You can always give more drug. You cannot take it back when you give it via IV, right? So that's one of the problems, especially when you're giving kind of bolus doses like that, that once it's in the system. You can't really do a whole lot about it at that point, right? That can be an issue. And then I mentioned the extravasation. With some drugs, it can be very, very detrimental. Some drugs, it's not going to be a big problem, but you'll run into specific instances. So this is one we run into in the emergency department all the time because people come in for seizures, and phenytoin is a common drug we'll use for those seizures, right? All right, and so one of the things I'll talk about is going to be parenteral drug administration. This is basically anything being given via by injection, basically. I talk about IM, I talk about sub-Q, when I talk about IV, these are all parenteral drug administrations. They're being given via injection. And so this is another route, subcutaneous, sub-Q. The nice thing about this is it's good for patients who are going to have like an implanted medication. So like some birth controls are going to be implantable formations that will slowly release drug out over several years. They're also good for self-administration. So it's very easy for a patient, relatively speaking, to be trained on how to administer a sub-Q shot, say of insulin, or say of like a blood thinner, than it is for them to learn how to get their own IV. I mean, there's some patients out there that are very good at finding their own IVs, but they're probably not coming into the hospital for, you know, any good reason at that point. So we don't want patients to start their own IVs. We want them to use something like a sub-Q administration, much easier for them. Usually, you find like the abdominal tissue is going to be the best place for that, because again, that is going to be better for your patients to use it. The other thing though is you have to consider, you know, is the patient, do they have the dexterity to do this sort of thing? You know, for rheumatoid arthritis, you know, one of the big things you'll find is they have kind of joint deformation in the hands, and a lot of their products, their drugs they're going to be administering are going to be these pins that they will inject into themselves essentially, right? They have a little needle on the end and they inject it. If they don't have the dexterity or the hand ability to do that, then they can't administer that drug, and they need to get some help or something else needs to happen. So that can be an issue there. And some other problems, you may see some pain, some necrosis associated. No one wants to inject themselves more than they have to. But again, this is going to be one route if the drugs are not going to be active via the oral route. Okay, next is going to be intramuscular. Nice advantage here is, again, it's going to have high bioavailability, typically faster onset than sub-Q, slower than IV, you'll find. Because, again, you need to have that blood flow actually make it to the muscle to actually pick up the drug to take it back to the central circulation. So still pretty quick for the most part. The drawbacks of this is going to be pretty painful in comparison, especially with larger volumes. So, for instance, when we have to give antibiotics, so say for instance, like we have a lot of kids who come to Orlando, we're a big travel hub, right? Because people like to go to Disneyland and Universal, etc. So we have a lot of Make-A-Wish kids. You know, they'll come in, they're here for their trips, and so they get sick and they come over to our ER, right? So one of the things they don't want to be laid up in the hospital all the time. So in some cases, we'll try to give them a shot of antibiotics via IM, so that way they can still go back and go to the park, and sometimes they'll come back the next day, get their next shot of antibiotics, but it's always the IM route. And sometimes you have to realize that the volume's too big, because again, the more volume put into that muscle, the more painful it's going to be. Sometimes you have to actually split it up into, like, say, 2 syringes. And people are like, well, do I want the muscle to hurt worse with the bigger injection, or do I want to stick them twice? What's going to be worse? So sometimes nurses have strong feelings one way or the other. But it's one of those things where more volume means more pain with the IM shot.
Does that affect the efficacy of it in different locations?
No, because you're going to find that overall it's not going to make a big difference as far as the same amount of drug should get into the system. It shouldn't really cause a big difference there. Yeah, but yeah, sometimes it just depends. Sometimes we'll do 2 shots into either thigh. Sometimes we'll just do 1 big shot into. It just depends. And the age of the patient and the size of the patient can dictate how much you might want to give. So for instance, 3 mLs might be the most you want to do, say, like for an adult patient. And again, 3 mLs, that's not a whole lot of volume to get your drug into. So usually the drugs have to be really concentrated in order to make that work. Yes, ma'am.
My understanding is actually better to like switch up the sites all the time.
Okay, yeah, so if you're going to be doing something, say, for a long period of time, or say like every day or whatever happens to be, yeah,
And you only want to like switch up the spots.
those cases, yeah, you do want to switch up the sites for sure. This is going to be more for, like, when I'm talking about IM, this is going to be more of like a single dose sort of thing, or you may get like a dose for 3 days sort of thing. So that one would not be as much of a concern. Yes, you're right. For sub-Q shots and things like that, you typically want to kind of rotate sites or go to different areas. Sometimes you can see changes that will occur by kind of continuously stabbing the same area. In some cases, you have things like lipodystrophy that can occur and whatnot. So yes, you're absolutely right. You do want to rotate sites, especially if they're going to be on it for a long period of time. Yeah, and they're injecting themselves like several times a day, as a lot of diabetic patients have to do. You know. Anywho, usual injection sites can be things like, the gluteus maximus, the deltoid, vastus lateralis. Those are the most common ones you're going to run into for IM administration. The other things you have to consider, though, are going to be things like, well, is the patient very obese? They may have an altered absorption, right? You may have to make sure you're using the right needle length to actually make sure you actually get down to the muscle in those cases. Or if they're emaciated, maybe you have to consider may not have good absorption. Maybe you need to use a shorter needle in those cases. Things like exercise and heat, how do you think that might affect absorption? Probably going to increase it, right? Because again, as I'm exercising, I have more blood flow going to the muscle, should be absorbing a little bit better, right? So again, those are all things you have to consider there. Next, real quick, the intrathecal administration. Normally, if you guys remember the blood-brain barrier, normally likes to keep things out of the CNS. We don't want things to go into the brain that doesn't need to be there. That includes bacteria, that includes drugs. But sometimes we want to get drugs directly into the area, and so we can do intrathecal drug administration. And so usually it's done by via epidural. We can inject things like chemotherapeutics. We do that very frequently for some of our leukemic kids over at Nemours. We can do it with antibiotics potentially, and then even with anesthesia, probably the more common one you're going to run into, especially like an OB-GYN rotation or something. Usually we can inject things like local anesthetics and like an opioid right into the intrathecal space, and that way it's nice because you get very kind of localized sort of effects depending on how high the drug goes up the spinal cord. You'll find the drug effects will differ as well, because again, when you have someone who is going into labor, you want them to have relative numbness from the waist down essentially, but you want everything from the waist up to be still present and awake and aware and feeling essentially, right? So that and that's why by modifying how the patient's laying or something like that, you can actually change where the drug's gonna be working and how far up it'll go essentially. All right, up next we have sublingual administration. So this is just like you might imagine, underneath the tongue. The nice thing about this is it actually bypasses the first pass effect. There are several routes we'll talk about that bypass first pass. And again, oral is going to be the main one that gets hit with that. Because this doesn't enter the GI tract at all, this is why it's going to bypass the liver there. This is only good for a certain number of drugs, and a lot of them do not have sublingual administration available, because it all depends on the drug itself and how well it's able to be absorbed. Probably the more common one we run into is going to be Zofran. I'm sure people have heard of Zofran before. What do you use it for? Nausea, vomiting. Right. So if you have someone who's very nauseous, do you think they want to start swallowing pills or liquids and things? No, they probably don't. So a sublingual tablet, it's a lot easier, just let it absorb passively underneath the tongue, and it can help to deal with that nausea and vomiting. A lot of people call that liquid gold in the ERs because it's such a good med. A lot of people come in nauseous, it'll fix them up real quick. And the only disadvantage here is really that only a relatively small number of drugs can be used sublingually. Anyone know any other drugs used sublingually? Yeah, nitroglycerin is the other big one you're going to see there. So you have either like nitro spray or nitro tablet for patients with angina, right? They develop chest pain. Who says angina? Some people say that. I had one year, it was funny. The students were like, well, only you and the cardiology person says angina. Everyone else says angina. I was like, shouldn't you listen to the cardiology guy? Like, he's the one that says it all. There's always that, and there's like tinnitus. Like, is it tinnitus? Is it tinnitus? I lived next door to an audiologist for a period of time, and I asked him, and I was like, what is it? And he said, I say tinnitus. And I was like, okay, I'm going to say tinnitus from now on. You're the expert, not me. Anyway. I don't care which way you say it, but angina just sounds, I don't know. I like angina. Sounds a little bit, I don't know, better. Anyway. All right, so next up, we have the oral route of administration. This is going to be far and away the most common route of administration you're going to run into. It's the most safe method from, you don't have to get an IV line. You don't have to worry about, what's the disadvantage of having like an IV catheter placed for a long period of time? Infection, yeah, infection is going to be a huge thing, right? And again, in the hospital, prevention of secondary infections is a huge deal. Because again, when you have a patient come in for a heart attack or they come in for whatever, but then they get a secondary bloodline infection or bloodstream infection because of the lines that you place, do insurances want to pay for that? Heck no, they're not going to pay for that. So again, that's on you now. That's on you as a hospital. So if you can get things orally, that's great. Now, oftentimes what we're focusing on in the hospital is getting patients switched from IV meds over to oral meds as best we can, so we get those IVs discontinued. It's also pretty economical, pretty easy to do. Disadvantages: requires patient compliance. I say compliance. What does that mean? Yeah, they're actually going to do what you're telling them to do. So again, patients have to be willing to take tablets. I've had 30-year-old patients who refuse to take tablets. And I'm like, you're an adult. Take a tablet. Like, no, I can't do it. I'll just throw up. And I'm like, all right, whatever. Patients have to be able to swallow, right? So again, if you imagine like a stroke patient or someone with Parkinson's has very bad dysphagia, they may not be able to take something like a tablet or a capsule. So sometimes you have to modify the dosage forms to help with that. So maybe the liquids, or depending if you have certain lines that will be going from, like, say, the oral cavity down into the GI tract itself, like that can sometimes get around that. The other thing is the first pass effect is going to depend entirely on the drug. Some drugs have a huge first pass effect and are no good orally. Some drugs have a very low first pass effect and they be absorbed very well. And in fact, when you're looking at drug doses between IV to PO, some of them you'll find are identical doses, right? So that way that it's very good bioavailability if you don't change the dose at all. In some cases, though, you have to go down to maybe like 10 times the dose orally as you would give IV because the bioavailability is so poor, right? So that's always something you want to look at. I had one patient who was coming in to the ICU. I can't remember what they're coming in for, but they were on levothyroxine at home, right? Synthroid. They use it for hypothyroidism, and the provider wrote for an IV dose because the patient was NPO. They're not nothing by mouth, and so they were trying to keep their home meds going. They didn't want their thyroid meds to stop, so they're going to write for an IV, and they wrote for the same dose IV as they were getting orally. And I was like, I don't do a lot of IV levothyroxine. Let me look it up. It's one thing I always tell you: look everything up, even if you're completely sure. Look things up. You can't never hurt yourself to look things up. Anyway, so I looked up and I was like, oh, actually, you have to like cut your IV dose by half in order to get the same bioavailability, basically to account for the bioavailability to oral dose. So I called her up and said, hey, we should probably drop this by half. She's like, okay, let's go ahead and do that. So those are the things you have to take into account. And again, the one thing I'm trying to teach you guys is to have the skills to not have nerdy pharmacists call you up and try to bother you with a bunch of orders, right? So again, that's my main goal is that you guys are going to be so good that you'll never be called up by a pharmacist because you're doing anything perfectly to begin with. Okay, so those are things you can start to look up when you're writing orders. Okay, other things are going to be like food-drug interactions is a huge thing. So say, for instance, you have a patient who has, let's say a UTI, you have a urinary tract infection, and you give them a dose of an antibiotic. Let's say we're going to go with ciprofloxacin, right? It's a fluoroquinolone, it's a type of antibiotic, and the patient comes back a week later and they still have this raging UTI, and you're like, what the heck happened? You say, are you taking your medication? And they say, absolutely, I took my medication just like you told me to. Took it twice a day for the whole week, and nothing helped. Next question I want to ask is, well, how were you taking it? What were you taking it with? And in this case, with fluoroquinolones, they bind up very readily to calcium. Calcium in milk, especially, right? Especially older patients who worry about their bones. What do you tell them to drink a lot of? Gotta get a lot of milk. So this is a very common drug interaction you run into. So even though the patient was being compliant, they're taking it like they should, they didn't ever absorb the dose because the calcium prevented it from being absorbed up, and then the infection never got dealt with. Okay, so this is one of those things you have to kind of take into account. Make sure you educate them to separate out if this is going to be an issue. Separate out the drugs between milk, only take it with water, etc. Right. You can find different dosage forms that are out there, certainly capsules and tablets and all of that. Some cases you may have what we call enteric coating. Anyone know what that means? Yeah. So basically, it's an acid-stable sort of coating on the medication, so that when it's in the GI, and when it gets down to the stomach where the pH is like 2, it will not be degraded. And then once it gets into a more basic medium of the small intestine, that layer will then dissolve away because it's going to be dissolvable in a higher pH, and then the drug will be able to be absorbed. That's what we talk about enteric coating. It just means it's resistant to stomach acids. And then you also find there's a lot of medications that taking medication, what's easier to do or easier to be compliant with? Taking a tablet 1 time a day or taking it, say, 6 times a day? 1 time a day, right? So again, anytime you can limit or try to limit how many doses a patient is taking to make it easier for them is going to be better. I'm a pharmacist and I cannot take a multivitamin every single day. I am terribly compliant even with that. Imagine a patient who's 80 years old trying to take a med several times a day. It's very easy to see how they can get non-compliant without even really meaning to. So using things like extended release formulations that are going to slowly release throughout the day can help with that. Instead of giving a med 3 times a day, maybe you only take it 1 time a day now, right? So that can be a very useful way to help to get around that. Okay, up next is the rectal route, PR if you see this, and this is good when patients cannot take oral medications. One thing to note there. And so the nice thing here is it bypasses a lot of that first pass effect because the rectum is very vascular, it has very good absorption, and you don't have a lot of that drug going to the liver as the first place it hits there, which is nice. Other things you may run into, some disadvantages, you can have maybe incomplete or irregular absorption of some medications depending on what you're dealing with, and then looking at patient compliance. So, if you're dealing with, say, like an infant, like a 6-month-old, they don't really have any way to fight you if you're going to try to put a Tylenol suppository in the rectum, right? So they're just going to lay there and they kind of do okay with it. However, if I try to do it to like a 17-year-old, they're probably not going to like that very much, right? So again, think about your audience, think about who your patients are going to be. Kids are usually going to be a little bit more compliant with these than like adults. They usually don't like them. It's like, let me just take a tablet. Let me just do that if I can. Always make sure, take the foil off first. Otherwise, it's a big pain in the butt. I'll tell you that for sure, right? Okay. Yeah. So a couple meds you're going to see is like Tylenol suppositories are a big one, usually like good for fever. You can find some laxatives and things like that are given via this route. So just know this is a available option. The number of drugs you're going to use is going to be relatively limited though. The other thing to note here is that certain patients cannot receive anything rectally. So one of the things we'll see, we'll learn later on, is that patients who are neutropenic or patients that are highly immunosuppressed, you do not want to give them anything rectally. And then one of the reasons for that is because if you have any kind of tear or injury to that mucosa, is the rectum a sterile environment? Heck no, it's not. You can have translocation of bacteria, and those patients can develop infections. So, for instance, with our cancer patients we deal with, who we're giving them drugs to wipe out their immune system, we don't give them anything rectally because we know even like temperature monitoring, we don't do anything rectally because we worry about them getting an infection from that. And oftentimes, when you have those kind of patients, it's not the cancer that actually kills them; it's the infections they get from our treatment in some cases, right? Next is the inhalational route of administration. Advantages here is it's very good to get the drug right where you need it to, right down into the lungs. We use this mainly for things like asthma medications, however, can have very fast absorption for things like crack cocaine potentially, right? Now this, as opposed to many other dosage forms and other routes of administration, is so reliant on the patient's ability to use the dosage form appropriately. Right? So this person here, probably not going to get a whole lot of drug that way, right? So technique is super key here, and that's why education is so important. There are some ways we can help to get around this. So for instance, using things like valve holding chambers, and we'll talk about this in the asthma section later on, but technique is super important. If you have a patient who's not going to be able to coordinate pressing down the canister on a meter dose inhaler and inhaling it appropriately to get the drug in the lungs, guess what? Either breathe it out or it's going to go down in the GI tract, right? So technique is super important here. We'll talk more about that later on in Pharm 1. The different varieties here, you can have things like meter dose inhalers, which is what you think about with like a typical sort of like asthma inhaler. There's also things like dry powder inhalers. So anyone ever seen like an Advair discus or like a discus sort of thing? That one, instead of having a propellant in the canister that it would force the drug out, this is actually reliant on the patient to breathe in forcefully in order to get that drug down. Well, what if they have respiratory disease where they can't actually breathe in very well, right? That may not be appropriate for them. Then the other thing we have is nebulization, where basically you're going to be putting the medication into a tiny cup that vibrates a very high frequency that helps to nebulize the drug, makes it into a little more of a gaseous sort of form, and the patient can breathe in it a little bit more passively. So depending on the patient you're dealing with, whether it's a kid or an adult or geriatric patient, they may one may be better than the other for them potentially, right? And again, this is why it's so important to do the teach back method. You guys are familiar with the teach back method? That's where I teach the patient something and I have them teach it back to me to make sure that they understood what I said and make sure everything connected. So I like this clip here. Let's see if it can get to work. Hopefully it'll work. Here we go. And you may think that's too dumb. No one has ever done that. I guarantee you that someone has done that, right? Just like you see the signs that says, like, don't do this stupid thing. Someone had to do that to get someone to make that sign in the first place.
There was a patient where they were teaching him how to take his insulin, and they were showing him on an orange. And they're like, oh, you just like, you have to practice, and then they have him teach back. So when he comes back, like, it's obviously his like insulin levels are like terrible glucose levels. And they're like, what are you doing? And he's like, well, I'm so tired of eating oranges all the time.
There you go. Injecting the orange and then eating. But it tastes very good.
I had a patient that was on fentanyl, and she kept using it, and she came back and said, I don't have any room for my fentanyl anymore. I said, what do you mean? She left the patches on.
Right, so it would like transdermal medications, like you take the old patch off, put a new patch on. Sometimes rotate sites, but yeah, so imagine she was just covered head to toe in fentanyl patches. Ooh, that'd be a fun thing to find. Yeah. Anyway, yeah, so patients do some crazy things, right? They're not all going to be medical geniuses like you guys are going to be in 2 years. You need to keep this in mind and make sure you kind of bring it down to their level. Like education is probably the most important part of your job when you're talking to these patients. Make sure they know what they're doing with these medications, right? Otherwise, you're just wasting their money essentially, right? Not getting any. Okay, the transdermal route. So this is going to be useful for some medications. Now, the big barrier here is that drugs have to get through the skin in order for it to actually be absorbed, right? So this is why only certain drugs can be used via the transdermal route. I mentioned fentanyl as one that you can use via this route. The nice thing here is it can actually help to increase compliance because many of them have enough drug on them to where they are going to be able to release a steady amount of drug over the course of several days. Some of them are only replaced every 3 days, some of them every 7 days. So that can be useful for helping with compliance and make sure the patient's actually going to take them, right? Again, not all drugs are going to penetrate. Do not want to use these on open wounds because that would actually increase the amount of absorption you'd have. And from my standpoint, from the toxicology standpoint, these are actually really bad because, again, what do you think is driving this drug across the skin here? I had to guess. Thinking back to like osmosis, not really osmosis, but think about things like diffusion. We'll talk about diffusion more later. But basically, it's based on this concentration gradient. So you need to have a lot of drug up here in the patch to force it through the skin. We'll cover this in later sections. But when you take that patch off, guess what? It still has a lot of drug left on it. And so if a kid ends up getting into it, they swallow it, guess what? Now they have a nice controlled release amount of drug going to be in their system until they poop out the patch, essentially. And actually, I had one patient who came in there, I think it was like an 8-month-old patient, and the kid was coming in, he was like, very lethargic, and his heart rate and blood pressure were looking kind of low, and they were just like, we can't figure out what's going on with this kid. All the medical stuff we worked up, and nothing, we can't find anything. And so I started talking to the parents, and I was like, well, what kind of medications are in the house? And I got to one, the dad was like, oh, I'm on a clonidine patch. And clonidine is a drug we use as an antihypertensive very frequently, and it looked like this kid may have gotten into the clonidine. He looked like a classic picture of that. And I was like, was there any chance that he got into this patch? And the guy's like, no, the kid's not even really that mobile. There's no way he could have gotten into this patch. I was like, are there any other kids in the house? And he said, yeah, there's a 2-year-old, their sibling. And I said, I bet that 2-year-old grabbed a patch out of the trash and fed it to the infant. And he's like, no way, there's no way that could happen. That would not happen in my house. And I said, all right, we'll see. 2 days later, that kid pooped out a patch. Crap, you're not. He had the patch. So you can start to see where my humor is going to go for the rest of the year here. But anyway, yeah, so that's one of those things where it was like, okay, this looks just like it, and and you have to think about kids are they're trying to help out, or they think, okay, my dad takes this medication, that must be good. I'm going to give it to my little sister, and right now, again, I have a 6-month-old and a 2-year-old, so I'm deathly afraid of when she starts to try to give her medications, quote unquote. But anyway, that's a big risk for poisoning we run into with some regularity. So we're going to cover other routes as we get into specific sections. We're talking about ocular things or mucous membrane-based medications. We'll talk about all those a little bit later on as we get to them in Pharm 1 and 2. Yes, sir?
For the transdermal, does it matter, we had a little debate on this, so does it matter, like for like nitro patches versus like 1 inch, you're supposed to 14 milligrams or whatever, does it matter if you use the inch, or can the same amount of medication be spread out and still do the same dose?
You mean like increasing the surface area?
Yeah.
Yeah, so if you were to increase the surface area, that would definitely modify how much absorption you'd be having, because one of the things you'll see with that diffusion is the bigger the area, the more flux you get, the more transition of that drug, right? So if you kept the concentration the same throughout that whole patch and you're giving it a bigger area, you would expect to see more drug be absorbed there, right? But you're just talking about the nitro paste more specifically. With that, I probably would expect to see whether you did an actual inch or more spread out. I don't know that would make a huge amount of difference clinically. But yeah, that is something to consider there, whether you actually do an inch or not. We'll talk about that later. That's kind of an interesting one as far as like healthcare providers actually getting exposure to that drug too, because do this transdermal. That's the other thing with transdermal stuff is that if you're using it without any gloves or protection, guess what? You might be exposed to it as well. So if you ever hear like someone putting nitro paste onto a patient, all of a sudden they start complaining of headaches, like the nurse does, then they probably didn't wear gloves when they're actually applying it. So that could be an issue there. But anyway, so again, we'll get into more specific routes as we get to them later on. Okay, so real briefly, I'll just talk about drug development, and then I'll finish up this section. We'll do that next. So again, how do drugs actually get out on the market? Well, they have to go through trials, right? They have to go through several steps to try to actually show that they are safe and effective. However, was that always the case? No, I mean, like Bayer, the maker of aspirin, I mean, they used to make heroin. They used to sell that stuff. Like, we have a lot of things that used to be done, and we didn't have a whole lot of evidence that they were safe or even effective, right? And again, even though as early as like the 1900s, like we didn't have a lot of regulation around a lot of this stuff. But the Food and Drug Administration, they regulate food, drugs, and also cosmetics are the other big thing they'll be under their purview. So you don't have to memorize these acts here, but I just want to kind of show you the steps that we took to get to where we're at today. But for instance, in 1906, we had the Federal Food and Drug Act, and basically they just wanted to make sure that what you said had on the label was actually on the label, essentially, right? It didn't have anything to do with safety, efficacy. You could be selling snake oil, as long as it had the actual snake oil on the label, you didn't have to show that it was effective at all. So again, not a whole lot of good regulation there. Later on, 1938, they had several kids, 105 kids died from this antibiotic that actually had a product called diethylene glycol in it. It's basically very similar to radiator fluid. It ended up killing a bunch of those kids. So after that, they said, okay, let's do this Food, Drug, and Cosmetic Act and actually show that these products are safe to administer, right? And then afterwards, you guys ever heard of the drug thalidomide? It was used for a brief period of time over in the UK. I don't know that we had any cases over here in the US, but it was used for nausea and vomiting associated with pregnancy. And so what they actually found is these kids were being born and they had this limb malformation. It basically looked like they had like kind of flippers almost. You can look at pictures of this. And so because I don't know the term when drugs cause birth defects. Teratogenesis. We'll talk about that later on, but that is a term there. Thalidomide was considered a teratogen, and so we got these reports of this happening in the U.S. and we said, whoa. We need to make sure we actually test this stuff beforehand to show that it's safe and efficacious prior to us actually giving these drugs out to people, right? So that's where basically our system now comes from today. There are 3 main clinical phases that happen before a drug actually goes onto the market. And basically what a company will do is they'll start with a bunch of test chemicals. They will try them in, say, potentially mice or other types of animals to show that they think, okay, we think this will be a good candidate for a human drug, essentially. They will then apply for what they call an investigational new drug application. When they apply to the FDA, this starts off their 20-year patent period, okay? So from the time they get that IND, they now have 20 years to get that drug to market and then recoup their expenses, essentially, right? So if that process takes 15 years, and they only have 5 years to make that money back, right? If it takes them 3 years, and they have 17 years to make that money back, right? Then, because they're the only makers of that drug, they're the only ones that can sell that drug for that period of time, right? Until the patent runs out, because then generics can start to come on the market.
Is it Viagra going through that right now?
I'm sorry?
Is it Viagra going through that right now?
Viagra probably is going to be, if it's not there, then it is probably going to be pretty soon, if I had to guess. Yeah. Yeah, because I mean it's been around for a good period of time now. So unfortunately, I've almost been practicing 10 years. So yeah, I mean we had Viagra when I started school. So yeah. Anyway, But looking at the actual number of people involved in these trials, phase 1 trials, we only have maybe 10 to 100 healthy volunteers that are being used to help determine like what the right dose is going to be for these patients, right? It's only maybe 100 people. They do not have the disease state. It's the important thing to note there. They are healthy individuals. In phase 2, once they show that, okay, well, we didn't kill anyone off of that drug and it looks like this is the dose we're going to use, they now do phase 2 trials where they have people that actually have the disease, and then they try to determine the efficacy. This is maybe only 50 to 500 sort of people in these sort of trials, right? Again, depends on the disease state. If it's something very common versus not common, hypertension, everyone's got hypertension. There's plenty of people that they can test this out on. Certain like genetic conditions, maybe only 2 or 3 people at a time that have that disease. That would be undergo a different process. But once it passes phase 2, it'll go into phase 3, where maybe you're dealing with a couple thousand people, and you're still trying to determine the safety and efficacy. Once you pass phase 3, then you can take it back to the FDA. You say, here's all our data, and they'll go through and they'll review it, and they say either yay or nay. And then if they say yay, then the drug is out in the market. Okay. You can see here, starting off, maybe 10,000, 25,000 chemical entities that they're working with. You'll see here that by the time they actually get to preclinical trials on animals, maybe only 10 to 20 actually make it to where they think this might be okay for humans, right? And then by the time we get to phase 1, maybe only 5 to 10, 2 to 5, 2. So they get weeded out pretty quickly based on what they find in these clinical trials here, right? So as you might imagine, how expensive do you think this is? Super expensive, right? So again, big pharma, probably pretty evil, but also it's an expensive business as well to run. So looking here, again, just another table kind of showing you a very similar thing here, but looking at the animal testing, seeing do we think this is going to be a safe and effective drug, and then they go through the clinical trials. Now, notice right here, this is when it actually makes it out onto the market itself. This is a phase 4 clinical trial. So who here has ever taken any drug ever? Probably everyone, most everyone. Guess what? You are all a participant in a phase 4 trial. Because we have only, by the time a drug comes on the market, we've only given it to maybe a couple thousand people, maybe 10,000 if we're lucky, maybe 20,000. Can you find 1 in a million side effects, that sort of numbers? No, the odds just aren't in your favor. So you'll find that when you enter a phase 4 trial, which is the post-marketing surveillance, they're still looking for side effects. They're still looking for things that happen in a very rare occurrence. And you may find things that cause drugs to be taken off the market. Have you ever heard of Vioxx before? It's an older drug that was used as kind of it's like an NSAID base, like ibuprofen, but it helps spare the stomach, and it was thought to be this revolutionary new drug. And what they found was it actually caused heart attacks, caused people to die, these cardiovascular deaths. And so they didn't realize that till they were giving it to millions of people. And then they said, okay, the chances are too high for this to occur. Let's go ahead and remove it from the market. So the whole drug just got pulled. Okay, that can happen. Again, after 20 years, this is when they can then become other manufacturers can come in and sell generic drugs at that point. Again, just another table. I'm not going to go over this, but you can see kind of the money that gets involved with each one of these different trials, and kind of we already talked about this here. But again, assuming they pass all 3, then they'll get their new drug application. That's when they actually get to go on the market. And again, the average cost to market for a single drug is around $2.6 billion. So again, they need to make their money back, right, to recoup their costs. But you're going to find that they'll do that via many different ways. But they only have maybe a short period of time to actually recoup that while it's still a brand new product. Okay, so any questions on that? And again, when you make a new enantiomer, when you say you go from cetirizine to levocetirizine, guess what? You got a brand new 20-year patent on that. So now you got a whole lot more time to make some money back on those products there. So you can see how it's good for money purposes. Yes, ma'am.
Are there any cases where like a company would be able to avoid let's say phase 1 or something like that? They could just skip ahead.
There are cases, and the only thing really comes to mind, and we deal with this sometimes over at Nemours, is for what we call orphan drugs or things with orphan indications. It doesn't mean it's just for kids without parents. It means it's for disease states that are very, very rare. So, for instance, like spinal muscular atrophy is a new, not a new thing. It's a genetic disorder where these kids die very, very young. Basically, their muscles just don't work very well. They usually die from respiratory failure and complications of that. And it's a very, very sad disease state, but not a lot of kids have it. Right, so fortunately, we actually have some very cool trials that are going on over at Nemours, where we're doing things like, we're doing things like injecting these kids with viruses that will then encode the protein that they're missing into their DNA. We're doing things like, helping to replace some of the proteins that they're missing and helping to work better. And so you're seeing these kids, and actually I have one of my students, their nephews in it, they talk all about them all the time. But their nephew's in one of these trials, and I mean, he's roughly the same age as my 2-year-old, and by the time she was up walking and running around, he couldn't even turn over, right? He couldn't even roll over because his SMA was so bad. They did that trial to him, or he's in the trial currently, and now he can start to walk. So it's like medical miracles are happening. But with these sort of things, they're these orphan indications. They have to go through a different process because they know they're never going to get thousands of people to get in this trial because there's just not thousands of people with SMA, essentially. Yep. Any other questions I can answer for you? Let you guys go. All right. If not, work on your assignment, and I'll see you guys next time.